Okay. Well, welcome to GitHub Conference March 2018. So the first case I wanted to discuss today, most of us have heard about this case, but we'll see what you think, Race, and your team. So 70-year-old male, he come to the hospital under one of the oncology teams, hematology team, sorry, and he's been receiving high-dose IV methotrexate for his CNS lymphoma. Now, he came in with a creatinine of 100, so that's just mildly above the normal range for our creatinine. So his renal function is mildly impaired, is what I'm saying. And now this has gone to 433, which is markedly abnormal, obviously. And he's had a little bit of GI symptoms, but not much else. No obvious nephrotoxics on her medication that we can find. So my first question is, what do we think is going on there from that point of view? Any causes for the renal failure is what I'm asking. Do you have any ideas?
Well, I mean, obviously, you know, given what we know about the case, I would worry that methotrexate is either causing the renal failure or causing the dehydration, which is leading to the renal failure. Methotrexate is a mucosal poison. It's a general protoplasmic poison and one that we do worry about. With the creatinine rising like that, I would worry that he's not able to clear the methotrexate, and that's going to escalate his toxicity from it, regardless of what the cause of the AKI is. But, you know, this is kind of a vicious cycle. It's kind of like lithium. You know, they start vomiting, and then their creatinine gets worse, and then they can't clear the toxin. So then it's a vicious cycle that they're trapped in.
Yeah.
I'm afraid that that's what this gentleman is happening with him. Just going back, do you know if the methotrexate was dosed appropriately, or was it a single dose or a prolonged duration?
Yeah,
from what I understand, with methotrexate, it's really the prolonged durations, greater than 24 or 36 hours. That's where they really get into trouble.
Yeah.
So I would go back and ask if there was any dosing error with that.
Cool. No, we went back through that, and no, the dosing was fine. I can't remember what the exact dose was now, but it was their standard protocol. They only gave them one cycle, one dose, and then they monitored them afterward. What happened? So you're right, and those were the concerns as well. Obviously, it had happened by then. So methotrexate, also a nephrotoxic, is nothing commonly known, but it can cause nephrotoxicity. And
I think it's one where this is one where you alkalinize the urine, right, to try to keep it from precipitating. Is that something that you recommend, or?
No, we didn't in this case. Sorry, he did get it in this case. Sorry, but he had other things we can talk about. I'll just go through it. And so his concentration back at greater than 16 micromoles per liter. Now, I'll give you the normal range is probably less than 0.05, I think, from memory. So markedly elevated methotrexate concentration when they took it. His pH and potassium were okay. He looked a bit clinically overloaded with fluid a little bit. I think they were just giving him alkalization fluid therapy initially. So my question is, what would you do from here?
Well, there's two, besides the hydration and the alkalinization, you really have two options in terms of antidotal therapy. One of them is leucovorin or folinic acid. And that is basically bypassing the enzymatic step that methotrexate is antagonizing. And that's kind of the old standby. I think it's something that is relatively inexpensive and very commonly done for methotrexate. And it works pretty well. I'd probably start it right away with this gentleman. The other antidote, which is a little bit more controversial, is a newer agent called glucarpidase. Is that right?
Yeah.
And that basically cleaves methotrexate into a couple of inactive metabolites. And that's a very effective medication. However, it's very expensive. And it also cleaves leucovorin. So you can't use both the antidotes at the same time. You have to choose one or the other. Glucarpidase is often not stocked in hospitals. This guy is an oncology patient, so I imagine he's at a cancer center. And so they may actually be stocking this medication. But with some of the calls that we have with methotrexate toxicity, it's often the case that the hospital has never heard of this drug and they don't stock it because it's really expensive. And it takes 12 to 24 hours to get it to the patient, which is okay. Apparently, glucarpidase, you have like a 72-hour window to actually give this medication, and it goes in and cleaves the methotrexate and renders it inactive. So I would probably recommend immediately starting a leucovorin infusion, and then whenever the glucarpidase is available, there's actually some nomograms available now, and some of the studies with glucarpidase have some recommendations about when to give it based on the levels. So if you do have the level available of methotrexate, you can kind of base your dosing on that. And I forget what the actual number is, and it depends on the time course, but it's basically a nomogram that you can use to dose the glucarpidase. So that's something else that you could consider doing. That being said, that once you give the glucarpidase, it's going to cleave the methotrexate. However, the methotrexate assay is still going to see those metabolites, and so the assay is inaccurate after you give glucarpidase. So that the cost is an issue. The fact that you can't use leucovorin is an issue, and the fact that you can't measure methotrexate after you give it is another issue. So it's not a perfect antidote, unfortunately, but I do think that it's a very effective thing for someone who is in big trouble due to renal failure, and now you're really worried that they're going to have a catastrophic cascade of problems with methotrexate. And early on, before the methotrexate gets into the cells, you have that window to really just inactivate it as soon as possible if you have this glucarpidase.
Well, just to interrupt the case briefly, just want to say hello to the guys from Fiji.
Hi, guys. Hi, Arvin.
Just wanted to recap. So we're talking about a case of methotrexate toxicity in a patient who's getting a therapeutically high-dose methotrexate for lymphoma. So we're talking about ways of trying to mitigate toxicity from methotrexate. Just quickly, what's the toxicity of methotrexate? Anyone want to tell me from here? No? GI, nausea, vomiting, hematological suppression, liver renal function tests, abnormalities. Yeah, it's all those things, and bone marrow suppression is going to be the big thing if truly toxicity. And it doesn't occur. I think start to occur earlier than later. So the other option that we haven't discussed is, can this be dialyzed?
Yeah, good question.
Can I help you out?
I don't really think of it as like the first thing that I think of with methotrexate.
Yeah.
That being said, this guy's already in renal failure, so he may have dialysis in his future nonetheless. Yeah. I just don't know if you can remove methotrexate with dialysis.
So I'll tell you the volume of distributions, 0.4 to 0.8 liters per kilo, 80% excreted kidney, 50% protein bound. And there have been case reports of people using intermittent hemodialysis to clean methotrexate. So maybe more in the hematology literature than the toxicology literature, but there have been case reports and case series on that using. So it can be cleared.
Okay.
So in this case, it was probably going to get dialyzed on the basis of his kidney function is not improving anyway, and he's got the level. So why not just do that? You can still give him leucovorin. I don't know if you need to double it or not, but that's what happened. So he got dialyzed, and his concentrations came down markedly after a couple of bouts of intermittent hemodialysis. So therapeutic thing to talk about with carpetase, just and it's very expensive here in Australia, and a cost of treatment would probably be about $44,000. Yeah, so it was very expensive form of treatment that may not have added. If we didn't have dialysis, well, it would be unlikely, but you could consider that. But it's a expensive treatment that wouldn't have treated his renal failure either. So sure. Anyway, just something else to think about when you think about if you get these patients. Before I go further, anyone from Fiji want to share any cases before we go on? Hey, Dennis. No, we'll keep on going. Okay.
No, we don't have any case this month.
Okay, you can just have a listen. If you have any questions, just ask. Race, do you want to talk about yours before we go on anymore?
Sure. So we had a couple of interesting cases in the last week or so. The first one was in the Los Angeles area, a 24-year-old male. He ingested a drug in a suicide attempt that did not belong to him. Apparently one of his relatives has schizophrenia, and this drug was clozapine. He took several tablets. He came in drowsy, disoriented, with some tremors. He had some frothing at the mouth. They really said that he has a lot of secretions and hypersalivation. His blood pressure was normal, 120/65. Heart rate was fast, 142. Respirations of 28. His stats were 96%. However, later on, he became more hypoxemic, and his stats started to drop down. So he ended up getting intubated. Now, after intubation, the ER physicians noted some interesting findings that he had myoclonic jerking all over his upper body. No rigidity, but lots of jerking activity that was not thought to be seizures. He was not hyperreflexic. They maxed him out on both midazolam and propofol, but he still continued to have these really interesting and sometimes violent jerking motions. So that's when they decided to call the Poison Control Center. He was also a known drug user, and he had access to meth, and hydrocodone, which speaks to the opioid problem that I'm sure you've heard about here in the U.S. So they called us asking, what this could be. The last piece of data I want to share with you is that his temperature was 102 Fahrenheit. So what do you think is going on? I'll make it a multiple choice question. So one of the things that we thought was methamphetamine toxicity. Another thing that we thought of was benzodiazepine withdrawal. Another thing that we thought of was serotonin syndrome. Another one was neuroleptic malignant syndrome. And so among these choices, which do you think is actually going on and why? So you have a gentleman who's hyperthermic. He's altered, requiring intubation, mostly because of aspiration and hypersalivation. And then now has these jerking motions all over his body.
What do people reckon from here?
Is he normally on any other medications?
We didn't know if he was himself on any other medications. So this was his aunt has clozapine, and so this is a atypical antipsychotic, and he ingested what sounds like a handful of clozapine. So
Probably not neuroleptic malignant syndrome, just from not from an acute overdose from an antipsychotic, so it won't be that.
okay,
Yeah, all the features in terms of hypersalivation and the decreased conscious state and so forth are all in keeping with clozapine.
okay.
In terms of the chronic jerking, it's a bit, I don't know, maybe clozapine does that. It's hard to know whether it's an extrapyramidal effect. But
Oh yeah,
I-
that was another thing in our differential. Is this a dystonic reaction? You know.
but he's hypothermic, so it's hard to know what that's about as well. I mean, the withdrawal, I mean, would he be withdrawing from a drug as well as taking an overdose of clozapine? Probably unlikely. And withdrawal of benzodiazepines doesn't cause myoclonic jerking. So I don't think it's that.
Yeah, and it didn't really respond to benzos either. I mean, they gave him a lot of benzos both before and after the intubation.
I'd probably just cool him and
So
see what happens.
it sounds like you're leaning towards serotonin syndrome, Zeph.
Well, he hasn't taken a serotonergic agent.
What about clozapine? It's an atypical antipsychotic. It's got some serotonin effect, doesn't it?
I don't think so.
Oh, really?
You had clonus?
He's got no clonus. It's all just jerking activity. I mean, I asked the doctor myself. I said, check his ankles for clonus, see if he's got clonus. And they're not describing that. But, you know, he's got hyperthermia and he's got this funny neuromotor exam.
Usually antipsychotics are anti-serotonergic. I'm not sure specifically. So I wouldn't call it serotonergic.
Okay. So I guess
No,
that begs the next question. That begs the next question is, would you give him anything specifically to treat it? Namely cyproheptadine or bromocriptine if you think it's NMS. Sounds like you don't.
I don't think.
I'm leaning towards that too because I've never heard of a single acute overdose of an antipsychotic causing NMS.
Yeah, never have I.
I don't know if you guys have ever seen that or not.
No.
You know, it's typically a very chronic, low-level exposure over days to weeks that creates the NMS. And this guy doesn't have rigidity, which is another key feature for NMS.
And it's also key feature serotonin as well if you're hypothermic. So I don't think it's that either. I'd probably just paralyze him and cool him.
Okay. And that's what they did. He ended up having shivering the whole night and really even for several days afterwards. He's now 5 days out. Do you know if we called him back today? Or we called yesterday and he was still having some of these shivering episodes. But we found out that for whatever reason, they had given him meperidine as well, which is a very uncommon drug here. But meperidine is a classic contributor to serotonin syndrome, as you guys are probably aware. And so that kind of made me think even more strongly about serotonin syndrome. And we actually ended up recommending cyproheptadine just to see if it would help because it sounded so much like serotonin syndrome to us. And we haven't gotten any communication back whether it was working or not. So.
Are you saying that clozapine is a 5-HT2A agonist?
2A, yeah. That's the information that we're getting.
Okay. I would have thought there would have been an antagonist because most antipsychotics are, but interesting.
Yeah, some of the atypicals are actually pro-serotonergic, like for example quetiapine, and they kind of help with depression a little bit. So I don't know. I think of them as actually sometimes contributing to serotonin syndrome. I've seen quetiapine do it sometimes. I've never really dealt with clozapine. Clozapine is kind of a nasty drug anyway because you have this other side effect, especially in chronic dosing of agranulocytosis. And agranulocytosis is, again, not something that you expect with a single acute overdose. I don't know if you guys have seen a lot of clozapine or use it, but it takes a lot of paperwork to get clozapine to a patient here in the U.S. Just because there's so many black box warnings and stuff like that. And so we don't often see cases of clozapine toxicity just because it's very rarely used here. But, I've seen a couple of cases of it where they have very dense altered mental status and the hypersalivation, and it can often lead to aspiration pneumonia, which is something that this guy got also.
We were just looking up the clozapine affinity for 5-H2A, and it looks like it's a potent blocker. So serotonin could be
Oh, it's a
probably
blocker.
yeah, it's a blocker. So,
Huh. Interesting. Yeah.
Yeah.
Yeah. I don't know exactly what's going on with this guy. I mean, you know, he had a high temperature for sure very early on, and you know, maybe he got into something else that we haven't quite figured out yet, or it's a different process. Certainly, infection, at least on day 3 and 4, is something that we were really worried about. So we gave him the recommendation to give antibiotics. And beyond that, it was just kind of interesting because, you know, over and over, every time we called back about this guy, they said that he was shivering, he had these jerking movements, and these really funny reactions, which, you know, I don't know. I think that there may be some dopamine issues going on there, like a dystonic reaction or something that we didn't really know exactly how to treat. It didn't feel right to give him Benadryl, but then again, the benzos weren't really touching him. So I think that as of yesterday, the ICU doctor was going to try phenobarb just to help calm him down a little bit.
Sean mentioned anticholinergic toxicity potentially wouldn't account for the neuromuscular symptoms.
Right.
But potentially maybe that's contributing to the fever. I remember you can get idiosyncratic reactions to clozapine. People can get people can get hypothermia.
Oh yeah, okay.
Obviously the myocarditis is one thing that I don't know if you
But not in acute overdose.
but not in acute, but as an idiosyncratic reaction, you can get these kind of things potentially post-starting it. But I don't know if that's part of the whole picture, and it sounds like it's probably going to see some kind of mixed picture from whatever going on. Either way, it's probably supportive care and monitoring. Did this patient get a CK or a troponin done? Do you know?
They got a CK. The CK has really been normal, surprisingly, just like 79, and then the next day it was like 100. So he really didn't have any rhabdo. I don't know if he got troponin checked. It's not reported in our documents here.
Right.
He's 24, so presumably young and healthy.
Yeah, no, interesting case. You guys have anything else to add to that?
Neurotransmitter soup.
Yeah, neurotransmitter soup is what we call it. I think it's a mix of
exactly.
Potentially a combination of effects from clozapine here, but maybe not serotonin toxicity is potentially. I mean, usually if you're getting serotonin, you usually get some kind of rigidity if it's severe, if you're getting hypothermia. Yeah. I mean, you might not get rigidity, but clonus seems to be a first part. All right.
I think they should do an EEG as well, just to rule out actual seizures. I mean, it doesn't sound like it's seizures, but at this point, it's probably worth doing if he's got these on day 4 or 5, you know?
I mean, all the opioids that he might have been on can give you some serotonergic access to some degree, but not. It just varies between different agents, but it might not. Doesn't sound, from what we're saying, potentially could be other things.
I was really surprised that they used bimperidine. I haven't seen that in like 10 years.
No. We don't. I mean, we don't use it very frequently here either.
Yeah.
All right. If there's anything else, we'll move on to the next one. So this one was just more of a discussion of maybe just a learning point for our fellows as well and our registrar. There's a 4-year-old boy. The mother thought he had swallowed a coin. About a month ago now, but we hadn't checked what the object was. The boy didn't go to hospital, get X-rays, and this is a call later. Sorry, this is a month later down the track now. So we get a call. The boy had been experiencing abdominal pain every couple of days, and he had been a little bit more irritable than usual.
You said this is a month later?
This is a month later, post swallowing this object. Possibly a coin. Full blood count, liver function tests, renal function tests, all normal. Abdominal X-ray performed normal. Possibility, differentials. What are we thinking? Potential. Could this be tox, or do we think not tox related? What would you ask for is my question.
Well, I mean, was it a metallic object so that it looked like a coin, but it was actually like a lead pellet, or, you know, I'd worry about lead. You know, I think lead can cause some abdominal pain.
Yep. Yep. So,
and that's an easy thing to check too. You just check a lead level. So that's probably something I would recommend.
Yeah. Yeah. Well, given we're at a tox conference, I suppose we need to think about tox-related things. So lead, yes, I would put that high on my differential contributors.
The other thing we see kids eating is like button batteries, which certainly resemble coins, and those typically cause problems very early when they're lodged in the esophagus.
Yeah.
But I suppose, you know, if there was an ulceration or something that developed in the GI tract, and now he's just got, you know, an irritated GI tract from some other foreign object, that would be something else that would be worth considering.
Yeah. No, definitely for consideration. And you're right, if it's a button battery, you know, they probably would have presented it earlier, much earlier.
Yeah.
And if it wasn't a problem, they would have been more. Obviously, having GI centers are allowed.
But I tell you, you know, a 4-year-old who eats a coin on day 1 is probably going to eat a coin on day 7 or day 14 or day 21. So just the fact that he presents a month later, I mean, you don't know what happened in that month. He could eat a coin every day. You know, it's like having kids. You know, you're a dad. These kids will eat anything. You know, it's like the vacuum cleaners. So you don't really. The timing is like really hard to determine. You know.
Yeah, that's right. So the well, the abdominal X-ray was reassuring. It was normal. So they actually the story is they actually gave us a lead level. They did do a lead level. The GP did one, so he was suspicious. And it was actually the mother had checked, and potentially it wasn't a coin. It was essentially a curtain weight.
Yeah. And that's typically, we see fishing weights, lead fishing weights.
Thinkers and other things, we see that too. Yeah. So the lead level that was done about 3 weeks, a month later, was 50 micrograms per deciliter, or 2.42 micromoles per liter.
Okay.
What do you reckon now?
Well, want to take that one?
Right? Is it still there? Is it?
Yeah, Serena says localization. So we got to absolutely find out whether the lead is still in the kid's guts or not. And if it is, we have to aggressively decontaminate them.
Well, there's an abstract at NACCT where these lead pellets got stuck in the appendix. And so there was all these little pellets in the appendix that they had to go out and remove.
So Serena mentioned an abstract from the last NACCT meeting where they described lead appendicitis. The pellets got stuck in the appendix. So I don't know. I mean, did you guys recommend a CT or any kind of fancier testing than just a KUB?
No, I don't think so.
You'd see it on a plane. It's pretty ready.
Yeah. You'd see it if it came up, and if it was a lead curtain weight, and that's probably what it was, probably passed by now. But given that he had symptoms, and now a whole month down the track, there must have been some absorption during that period of time. And it might have been in the stomach for who knows how long, maybe a few days to a week before he passed it.
Sure.
But given the abdominal X-ray was normal, we were probably quite safe. We thought that they weren't going to have any more foreign bodies in there. And as you know, lead, one of the main stores is in bone. not over 90% stored in bone.
Yeah.
So some of that's probably just his lead levels may have been higher prior to that, and plus there's probably a bit of redistribution going on now as well.
Oh yeah.
Know how much. Well, it gets excreted, but there's probably a bit of redistribution. So we opted to chelate, obviously, this child, and we gave him a course of chelation therapy. So we repeated the lead concentrations after the first course of chelation. What would you give? Just
Well,
as a
by
side
the way,
question.
yeah, I was going to ask, like, so the CDC has criteria, and I think that for us, the action level is 45.
Yeah.
So this kid is just above 45.
Yeah.
Mildly symptomatic, I would say, but depends on how bad the abdominal pain is. It sounds like there's no anemia going on, or there's no like blood.
No,
blood
nothing
work.
like that.
Yeah. So I'd probably feel comfortable just giving him Suxamur, just giving him an oral course of Suxamur. I think is it like 3 weeks or 6 weeks, something like that, and then rechecking the levels.
Yeah.
So I don't think he needs BAL. I don't think he needs to be hospitalized, but he does need to. You absolutely have to get it out of the gut before you do any chelation, because otherwise you're going to make things worse. And so
that's right. That's right. And so we did that. We did the Suxamur, and after one course and one therapy, we repeated the lead levels. A couple of weeks after that, and it had come back from memory at around 15 or 20 micrograms per deciliter. So still elevated, markedly improved. The question is, would you give another course?
Well, going back to your comment about the skeletal stores, did you do like x-rays of the bones or anything to see if there's lead lines in the bones, or sometimes they describe lead lines in the gums? Did this kid have stuff, just out of curiosity?
No, we didn't. And I think my thinking at that time was that why would it change anything, even if you did find
academic. Yeah, it's more just academic.
Yeah. So we didn't do any more X-rays than the initial abdominal X-rays. So, would you consider more Suxamur, or would you hold off, or what would you do with this patient?
That's a good question. I don't know.
He's abdominal pain. Sorry, he's still having this vague abdominal pain intermittently, and he's still a bit irritable. But we don't know how much of that was prior to him doing this anyway. So you could say he was a little bit lower than baseline, but
yeah, I'm not sure what I would do. I mean, I could see the attraction of doing more Suxamur, but I just feel like the yield will be really low.
Yeah.
And that it's probably something that's just going to take a while to leach out of his bones.
Yeah.
No matter what you do. And so I'd probably just bring him back to check him every couple of months and make sure that it was declining. And just explain to the parents that, it's kind of stored in a place that we can't really actively get at, even if we chelate. And so it's just going to have to kind of take its own course. And in the meantime, maybe you can give him, calcium supplements or something else so that he can make sure that his bones keep growing without incorporating more lead.
And that's exactly what we did, because our guidelines are based on very large RCT that happened before. Probably a lot of us were studying toxicology, so it was a randomized control trial looking at especially this cohort of children who had under the 45 level, and whether anything. About 800 patients randomized. And so what they did was they did follow-up studies, and there's obviously been even more follow-up studies since then. And they found that the main thing is IQ, really. They didn't find any difference in the IQ levels of the ones that did get Suxamur and the ones that did no major differences anyway. So I think that's what our guidelines are based on are these randomized controlled trials. I mean, there might have been a little bit of improvement in one or two domains, but that was not clinically, statistically significant. So giving them more Satsuma when we know that it's going to be stored in bone and kind of continuously redistributed is an expensive method of not really helping the child is not going to probably improve, and more of it's going to be counseling, really. The expectation that your child might not be scoring, that top mark, or it's hard to tell. It's really going to be on time and doing the developmental assessments on where he progresses from here. It may not affect them at all, but it might be that 1 or 2 IQ points that you might not be achieving in the end. So that's why we went with this patient. And it's about allaying the fears of the family, of course. Obviously, their thoughts were, why don't we just give another course? Why don't we just get rid of it? It's a whole discussion of that, where we see
that's tough.
Going. So that was one case. Did you have anything else, or we can go on to another case?
No, you can keep going. I have one more case, but why don't you do another one?
Okay. We'll do this one, and then you can tell us about yours. 29-year-old. He presents having increasing use, but he's been using about 350 nitrous oxide bulbs for the last 2 or 3 months.
Oh, nice.
Supposedly abusing it for over 2 or 3 months. Has been abusing it. He only uses on Friday, Saturday, and Sunday. So
It's not a weird.
Normal use.
just on the weekend. But he's been abusing it for years. Okay, I'm not going to tell you what he presented with, but what do we think he might present it? Nitrous oxide abuse.
He came in and he couldn't walk.
Potentially, yeah. So what do we think? So walk is what we've got. And why is that? Why do people think he can't walk? Vitamin B12 deficiency. Yes. Yes. So yes, he presented with progressive weakness in his limbs and paresthesia. The other word for the abuse is called nanging. Or have you heard of that term?
Yeah, one of my residents said that they went to Australia and that's what they called it there. They called it the nang nang. They get like a tinnitus or something. Or maybe that's the sound that it makes when you pop it. But he said it's an Australian slang term for these nitrous poppers, the nang nangs.
What in the States? Did they have a term? Did they call it anything in the States?
We usually call them poppers, just because the little capsules, they make a popping sound when you pop them, and they're used in these whipped cream canisters. And basically that's kind of the universal term that are used here.
Okay.
Or whippets. Sometimes they call whippets, just because it's used for whipped cream. But yeah, I had a case almost exactly like this where the guy was pulled over by the police, and the police looked in his car, and he had literally like 400 empty canisters in his car seat, like next to him. And he was like a habitual user. He'd been using it for years. And he would come in and out of the hospital with episodes of paresthesias and weakness, and then he would get a little bit better and then go right back to using. So, yeah, it's amazing how long people can go. It must be a very fun drug to do because they don't want to stop.
Mouthful of instruments.
We're just talking about the use of it as a dental anesthetic.
Yeah, I mean, when I did my EM residency, we had it. We used it for procedures all the time. Like, it was just one of those things that you use for conscious sedation. And every once in a while, we'd even give it to the patient. Just kidding, but yeah, no, it's notorious among the dental community, and then it's just notorious among healthcare staff. But it does cause it causes issues with the neuropathy because of the vitamin B12.
Right.
It oxidizes the cobalamin in the cyanocobalamin. It oxidizes the cobalt, so it renders your vitamin B12 inactive. And then it causes a megaloblastic anemia, so you can get an anemia type picture. With your very large MCV. But then the real reason that it got taken away from a lot of dental practices is because it leads to infertility. And so a lot of the dental hygienists and dentists were getting issues with their fertility. And so that's something else that it can do in chronic low-level dosing. And
the mechanism for reduced fertility rates? Or?
No, I don't know. Maybe people just lose interest.
So this guy, we didn't actually get his blood back, but he got vitamin B12 replacement. But my understanding is that I think some of these guys can get methemoglobin too, but sometimes these can be permanent. And despite vitamin B12 replacement, you might not get that.
From what I understand, it's kind of like a third. A third of people have permanent disability. A third of people will recover totally, and then a third of people will have residual problems even after high dose vitamin B12. And like with our guy, the last guy we had, we gave him like 7 days of high dose vitamin B12. We gave him IM shots like every day. And he got so much better that he left against medical advice to go back to do more drugs, to do more of this drug. So some people recover and some people don't. And this guy was happy with, he had sort of like semi-permanent recovery, and he basically was okay with that. And he used a walker to walk out of the hospital to go do more poppers. So
it's hard to get them off. Difficult.
By the way, do you know if the neurologist did any like nerve conduction studies or anything like that, or MRIs?
No, we didn't get the follow up in the end. What happened from that point of view? I'm assuming he got the MRIs and workup that he obviously needed to have.
Yeah, the MRI shows some interesting changes in the dorsal columns, which is where that's where the spastic paraparesis happens. Is that all those long tracts of your dorsal columns. So there's some good articles out there that show exactly where the lesion is. And so it's kind of an interesting thing that, alcoholics get this because of the vitamin B12 deficiency just related to alcohol. But then this toxin causes the same issue with your dorsal columns.
Okay, good. Did you want to talk about your other case that you had raised?
Sure.
Or not?
Yeah, we can talk about it. How are we doing on time?
Yeah, still got time.
Okay. I told my staff I love talking to you guys because I get the news from tomorrow. Give me some stock tips. Okay.
Talking from the future.
Speaking into the future, that's right.
As opposed to you talking about meperidine, which is talking about the past.
I know, right? Totally. Okay, this case is a wee bit tragic, but something I think worth talking about. It's about a 17-month-old. At 9 p.m. on Friday night, she took, we don't know how many, maybe one, maybe several tablets of her grandmother's Wellbutrin or bupropion. And the family watched her at home. They opted not to bring her in until she started to have seizures about 5 or 6 hours later. She had 3 seizures back to back, which, technically status epilepticus. She went to a local kind of peripheral emergency department and received a couple of rounds of lorazepam. That stabilized her for a couple of hours, and then she was transferred to a children's hospital later that afternoon, where she had even more seizures and then actually experienced a cardiovascular collapse. So she got several rounds of CPR, got intubated at that point, and then got started on pressors. And the ICU called us asking for recommendations regarding really how to manage, Wellbutrin toxicity. First of all, because they didn't really have any experience with Wellbutrin toxicity, they were wondering if this is even consistent with, an ingestion of bupropion. And if it is, then what specific treatments could be started to help mitigate the neurological and the cardiovascular toxicity that this child had. So I don't know if you guys have had any pediatric bupropion cases, but this is one of my, arch enemies, Wellbutrin. I hate Wellbutrin, and this is why. So I just wanted to share this case to see if you guys have had any experience managing these.
The ones, obviously, we've obviously heard of the severe cases. Also, what you probably alluded to, or will allude to, is the problems of treating the cardiac toxicity that's a result of this. I wonder, did they have an ECG? Did you say what the rhythm was?
We don't have the EKG. Apparently, the rhythm didn't show a wide QRS. We recommended bicarb for the wide QRS, but as you know, sometimes bupropion, it's really not related to sodium channel blockade.
No,
there's something else called gap junction blockade. Have you heard of this?
Yes,
so it can look like wide QRS, but it's actually not related to sodium channels. It's related to the gap junctions. And maybe why? Sorry?
The bicarb might not do anything.
Sorry, you're cutting out. I didn't hear that.
I said the sodium bicarb probably won't do anything then for the toxicity.
Yeah, well, I've seen several cases of this, and I've read some reports in the literature where the bicarb just doesn't help the way that you expect it to. And people think that it's related to the fact that it's not sodium channels that are being blocked. It's something else. And then there's some electrophysiology papers out there that show it's really these gap junctions that are being blocked, and that maybe intralipid would be more helpful. And in fact, that's kind of what we recommended. Is we said, go straight to intralipid and give her intralipid. And if that doesn't work, then start ECMO. So thankfully, the Children's Hospital where we're based has a very aggressive ECMO team, and they came and assessed this patient. But those are the two recommendations that I had. And then the last recommendation that I made was to give Keppra, which is kind of a newer anticonvulsant, but we're starting to use it a lot more. And to me, if the seizures aren't responding to benzos and they're not responding to propofol, then maybe Keppra might help take away some of the seizure activity, because I feel like that just makes everything worse in terms of, brain function down the line. So in this case, they had her on multiple dose pressors, and they kind of managed her overnight. And amazingly, they actually opted not to do ECMO because they were able to oxygenate this patient, and the kid had good pulses and good cap refill, just based on the pressors. And then they opted not to do intralipid either. Now, the thing with intralipid is once you give it, you really can't do ECMO again, or you can't do ECMO afterwards, because the intralipid messes up so many of the circuits and the monitoring and stuff that it's really incompatible with ECMO. So you're kind of stuck. You have to choose one or the other. And in this case, they opted not to do either one because the kid was relatively stable. And we're now 48 hours out from this cardiovascular collapse. And the child has not had any seizures in the last 48 hours, but is still requiring the intubation and is not yet waking up. So we don't know how much brain damage has been, had at this point.
Yeah.
But that's kind of where we are with this. We think we're over the initial, cardiovascular toxicity from the Wellbutrin, but this is something else where, multiple seizures and then cardiovascular collapse occurred. And so I think a learning point from a case like this is, if you have multiple seizures from bupropion, to go very aggressively and manage the airway very quickly, and possibly start the intralipid if you're going to go that route very quickly before they go to cardiovascular collapse.
Can I just ask, bupropion in Australia was marketed as a anti-smoking drug, not an antidepressant, and it's not very popular, and it's not used very much at all. So we don't see much of it anymore, although we did see a little bit marketed for this. But I believe in the States it's quite a common antidepressant.
It is. Yeah, it's used as an antidepressant.
Less with smoking.
Not as much as a smoking cessation aid, although that is something that we have heard about. But people like it because you don't have the weight gain and the energy issues that you have with the SSRIs. So it's a very popular drug here. I see very young people on it sometimes, like teenagers, which really scares me. And then the sustained release formulations can be a real nightmare. Another thing that came up with this case is, can you do anything in terms of whole bowel irrigation or charcoal? And we opted not to because the child already had seizures by the time they came into a healthcare facility. And I felt like that would have been an aspiration risk. We probably could have intubated a little bit earlier, I think. That's one thing that I learned from this case. But beyond that, I feel like there's really not a lot of consistency in the literature about how to manage these exposures in terms of decontamination, seizure prophylaxis, and then the cardiovascular issues that could be pretty refractory to bicarb. So,
yeah, the difficult cases to manage, and I think if they're severely cardiotoxic, I think ECMO is probably the way to go. If you had it in your center, I'd give that.
Well, the very first case report. The very first case report of lipid emulsion was in the late 90s, and they reported in the Annals of Emergency Medicine a young teenager who had overdosed on Wellbutrin, and she coded, and they did CPR for like 90 minutes, and the last thing that they did was give her intralipid, and then they got her back. So that was like the very first case report of intralipid beyond the local anesthetic toxicity, and that's what kind of kickstarted the intralipid fever. And it was a Wellbutrin case. So, there's kind of an old association between Wellbutrin and intralipid, although I'm not sure that it always rescues these patients.
No, and you don't know if they would have done better without it. It's hard. It's hard to really know.
It's very hard because then you can't start ECMO, and to me, it's like that's a really, that's a step you have to take with a lot of consideration. Because I feel like ECMO is the last line for these kids or for these patients. Yeah. And if you can't do ECMO because you gave intralipid, it's like, wow. To me, that was a real hard fork in the road.
Yeah. Well, you can. You'll just have to keep on changing your filter often, I suppose. And that's not great.
I don't know if there's any tricks. I wish I knew more about ECMO, but from what I understand, it's just a nightmare to do ECMO after you've given an intralipid, and it's just impossible.
Mm-hmm. Okay, great case. Great case.
Yeah, thank you guys.
So we can, I think we'll finish for today. Thanks for coming, Race.
Thank you guys. Always a pleasure.
In California, and thanks to the guys from Fiji. I hope you learned something, and obviously bring cases next time if you want to discuss them. And you might not see all of this here, but hopefully you learned something. And if you have any good cases you want to discuss, be sure to. All right. Thanks, guys. We'll catch you next time.
Great to see you guys.
Bye.
New conference room, Fiji.